Good evening. Good evening to all the viewers who are watching live and will be watching on the recorded version. Myself, Mukherjee, as you all know from the previous CME. Just a brief before starting the CME, let me just tell you, we have opened a WhatsApp channel. The link is in the description. Do make sure to go to that page, means go to that channel, follow that channel for more updates on NIH. And also, we have brought back the G forms, means the auto generated e-participation forms live, which is live right now. So you can just go to the link given below, and over there all you have to do just answer a few questions, and this process is same as like the previous few CMEs. We have stopped it for some reason, but you can just now get your e-participation certificate auto generated. Just make sure to give the proper email address for that. So before wasting any more time, let's just jump into 30 seconds countdown time.
Good evening, everybody. Good evening, sir. Good evening, sir.
Good evening.
We are now on the 81st episode of Online CME, organized by National Institute of Homoeopathy Alumni Association. And it's a remarkable feat, and credit goes to the entire CME team, led by our President Kalyani, sir, Dr. Chandrasekhar Pore, and other members, so that regular CME twice a month is now a reality. And tonight, on the 81st CME, we have a very learned speaker. And to start with, we have our inaugurator. With your permission, sir, let us call upon uh, tonight's inaugurator, Dr. Santosh Kumar Pal, alumnus from 10th batch of Dip NIH course, and he is the district homeopathic medical officer. And with this, I request Orko to bring on screen Dr. Santosh Kumar Pal, sir.
Hello.
You are audible.
Hello. Hello. Good evening. Very good evening to all. This is 81 CME organized by NIH Alumni Association. Our respected President Dr. Narayan Kalyani sir, popularly known as Kalyani sir, my beloved brother Dr. Bidyut Mukherjee, Secretary NIH Alumni Association, Honorable Speaker Dr. Pulakendu Bhattacharya, Lecturer, Organer of Medicine, DND Homeopathy Medical College and Hospital, Moderator Dr. Rajat Kumar Pal, also my brother, HOD Repertory, DND Homeopathy Medical College and Hospital, all the viewers, my friends, all the alumni of NIH across India and abroad, very welcome to tonight's CME program on psoriasis and its treatment in individualistic approach. I have the pleasure to be an inaugurator of a wonderful program like psoriasis, which is very difficult to cure. Let's start with a slow. Om Sahana Bhavatu Sahano Bhunaktu Sah Birjam Karo Baba Hoy Tejosina Bodhi Tamastu Ma Vidvisha Bahoy. Om Shanti Shanti Shanti. Oh Almighty God, helps to understand both teacher and students equally. Both we have been powerful by blessing of you. Both we can do work successfully, and we never be jealous to each other. Om Shanti Shanti Shanti. Let's start the program. I will hand it over now to moderator Dr. Rajat Kumar Pal to continue the program. Dr. Rajat Kumar Pal, please.
Namaskar, Dada. Namaskar.
Okay.
Good evening to all the viewers, to all the members of our NIH family. Respected my teacher, president of our alumni association, that is National Institute of Homeopathy Alumni Association, Dr. Devnan Kalyani sir. Pranam sir. My beloved Dada, Dr. Bidyut Kumar Mukherjee. He's taking the response to continue this seminar. Not only he and also my sir, Dr. D.N. Kalyani sir, Dr. Chandrasekhar Pore, and many our friends, my juniors, my seniors of Alumni Association, they're trying their level best to continue without hampering, without omitting in a month. So by every month, Alumni Association organizing 2 seminars. This is the 81st seminar of NIH Alumni Association. Today is the 8th October, and we have a very good and very necessary topic, that is the treatment of psoriasis and individualized approach through homeopathy. This is the psoriasis, basically the skin disorder, cause the rash, itchy, and scaly patches, most commonly in our extensor surface of our body, most commonly. And there is a very long-term suffering, and from our homeopathic approach, we may say that it is our chronic, mostly the chronic disease. In the classification of the disease mentioned in the organon of medicine, and it is very much painful to our patient. And in our OPD, in our different OPD in the government sector and in clinical practice, in private practice, my juniors, my senior, they are getting this patient in every month because it has been prevalent in the society nowadays. And it is commonly, according to the PubMed, because the psoriasis is a genetically predisposed autoimmune disease. That is it is published in a journal that treatment strategies against psoriasis, principle, perspective, and practices. In abstract, it is clearly written that psoriasis is a genetically predisposed autoimmune disease mediated by cytokines. We have a very good speaker, enthusiastic, soft-spoken, have a very good depth of knowledge of organon medicine, also have the sound knowledge on different areas of practice of medicine in gynae-obstetrics, surgery. He is my junior. It is my opportunity that I, being a moderator, I am moderating his lecture today. He is nothing but today's speaker. There's Dr. Pulakendu Bhattacharya. He passed BHMS from Midnapur Homeopathic Medical College in the year 2010. He passed MT Home from National Institute of Homeopathy 2015, 13 batch PGT. He worked as research associate homeopathy in CCRH, now working as assistant professor, Department of Organon of Medicine, DND Homeopathic Medical College and Hospital, Government of West Bengal. Without spoiling much, we are very eager to hear from him. Please, I am handing over the mic to our respected beloved junior. Now it is your time.
Thank you, sir. Am I audible, sir?
Yes, yes, you are audible. You continue.
Thank you, sir. Good evening, everybody. My respected teachers, Professor Dr. Rajat Kumar Pal, sir, Dr. T. Kalyani, sir, Dr. Santosh Kumar Pal, sir, and Dr. Bidyut Mukherjee. I am Dr. Pulakendu Bhattacharya. My today's topic is treatment of psoriasis, an individualized approach through homeopathy. I am directly going through this. What is psoriasis? Psoriasis is a chronic dermatosis characterized by an unpredictable course of remissions and relapse, and presents a typical site of papule and plaque, which are well defined, erythematous, surmounted with large silvery loose skin. Two words is very important: papule and plaques. That means, therefore, few changes happen in the epidermis and in dermis of the skin. In epidermis, there, due to increase of growth fraction, that is normally 30% cells are growing, but now in diseased condition, in psoriatic condition, 100% cells are growing. And another point is the turnover time becomes shortened from normal 60 to 10 days. That means the turnover time become 1/6. And these two factors, along with some changes in the dermis, that is proliferation of fibroblast, dilatation of the capillary loops, happen. From these things, few words which are we should know about that. One is growth, one is turnover time, one is dilatation, and one is proliferation. These are all related in a straight line, that is overgrowth. This thing we will appear in next few slides. Before that, it is the epidemiology of psoriasis. Approximately 1% of the population is affected. It's a chronic immune-mediated skin disease. Immune-mediated skin disease and chronic disease. That means 125 million people are affected with these skin disease. Age, two peaks are there. One peak incidence at 22.5 years, another is late onset, which is on an average 45.5 years of age. Both sexes equally affected, and mostly these are worse in winter season. Now, the pathophysiology. In a very short manner, we should learn it, pathophysiology, because to understand the homeopathic sense, to understand the disease, chronic disease, especially skin disease in a homeopathic sense, we should know it. Basic pathophysiology, what are the changes happening in the dermis and in epidermis. Basically, somehow myeloid cells, myeloid dendritic cells are activated, and which affect on the lymph nodes. Here in the presentation, we can show it that in lymph node there are activated myeloid dendritic cell activate interleukin 12 and interleukin 23. These are the factors which can trigger few helper cell. What are the helper cell? Th1, Th17, Th22. Actually, these helper cells activate some release of the few inflammatory mediators, inflammatory cytokines, that are TNF alpha, IFN gamma, IL-22, IL-17, like that. And these factors, pro-inflammatory factors, basically, these pro-inflammatory factors ultimately begin an inflammatory cascade, and these inflammatory cascades done few changes in the epidermis and dermis also, which are in the dermis it is vasodilatation, angiogenesis, which I already stated, and in epidermis there are skin thickening, erythema, and keratinocyte proliferation. And these basic 3-4 things are also related, which I have already told, related to overgrowth. Now, clinical features. Symptoms of psoriasis vary from person to person, but few common symptoms are there. Patches of the thick red skin with silvery white scale is a characteristic of psoriasis, silvery white scale, and that itch or burn typically on the elbow, knee, scalp, trunk, palm, and sole of the feet. Dry, cracked skin that itches or bleeds, thick ridges fitting nails. There are few nail changes are there. Some patients have a related condition called psoriatic arthritis, which is characterized by stiff, swollen, painful joints. And these are the clinical feature. And there are few bedside tests. We are all accustomed with that. That is Grattage test, and another is Auspige sign. We all know that. I'm not discussing here in detail these two things, but by Grattage test and Auspige sign, we can easily diagnose in our clinical setup the patient of psoriasis. And few remembering points in the presentation of psoriasis. We should remember these. Number one, these lesions are bilateral, generally. That means symmetrical. These appear mainly in the pressure areas and infrequent involvement of face. That means face are not commonly involved, and infrequent involvement of photo exposed part. Here are few nail changes, subungual debris, thickened nail plate, oil spot, pitting, discoloration. These are the few nail changes associated with the psoriasis. And we know that psoriatic arthritis, these are the arthritic lesions affecting the joints of hand generally, and uh, sometimes it is associated with, not all the times, but sometimes it is associated with the skin psoriatic lesion. Now, the types. You should know these types. Very common type is plague type of psoriasis, and another is gutted psoriasis. These are the two types according to morphology. That are morphological variants. Another two types, psoriasis erythroderma and pustular psoriasis. These are basically the complications of psoriasis. And according to site modification, psoriasis may be classified as four types. That is flexural psoriasis, scalp psoriasis, penile psoriasis, plantar psoriasis. These are the common type of psoriasis. Plaque psoriasis. This is the most common type, I've already stated, and it appears as raised red patches of skin that are covered by silvery white scale. Silvery white scale is the characteristic feature. The patches usually develop the symmetrical pattern on the body. Gutted psoriasis. This type usually appears in the children or young adults and looks like small red dots, typically on the limbs. Outbreaks are often triggered by an upper respiratory tract. After an upper respiratory tract infection, streptococcal throat infection, gutted psoriasis may be developed in a young child. Erythrodermic psoriasis. This is a rare variety but severe form of psoriasis. characterized by red, scaly skin over most of the body. Psoriasis often develops in people who have a different type of psoriasis that is not well controlled. That means not well treated, not well controlled cases may transform into erythrodermic psoriasis, and it's a severe form of psoriasis and it can be very serious. Pustular psoriasis. In this form, pus filled areas called pustules surrounded by red skin appear. It usually affects the hand and feet, but there is a form that covers most of the body. Symptoms can be triggered by medication, infection, stress, or certain chemicals. Pustular psoriasis may be appeared after frequent use of allopathic medicines. These are the types of psoriasis according to site, that means flexural psoriasis, scalp psoriasis, and plantar psoriasis. To differential diagnosis, perfectly diagnose a case of psoriasis, we should know the other diagnosis, related diagnosis. One is tinea, another is atopic dermatitis, and another is seborrheic dermatitis. It is very closely related to psoriasis, looking like similar pattern, but few differences are there. In rash description, in psoriasis, rash is sharply demarcated, erythematous, and scaly plaque. These three things important. But in tinea, there is a central clearing. That means in the central area, there is no scaling or plaques. In atopic dermatitis, it is pruritic, red scaly, but crusted lesion without distinct border. This demarcated area, sharply demarcation, is a characteristic feature of psoriasis, psoriatic lesion, not in atopic dermatitis. And in seborrheic dermatitis, red plaques are there with greasy yellowy scale, not white scale, silvery scale, greasy yellowy scale. And there are differences in distribution also. Psoriasis may appear in the knee, scalp, back, and many of the times it is a symmetric distribution of the body. But tinea can appear in any part of the body. Atopic dermatitis may appear in flexor surfaces, that is neck, antecubital fossa, gluteal fossa, and in seborrheic dermatitis, it can also appear in scalp, but in external ear, nasolabial folds are the main site. Less commonly upper trunk and ventricular areas. Now coming to etiology. Nowadays, it is said the combination of genetic and epigenetic phenomena has been suggested as the etiology of psoriasis. That means epigenetic and genetic. An epigenetic trigger over genetic predisposition. It's a very important line. It's an epigenetic trigger over genetic predisposition. Genetic factors are not the sole critical factor. Only genetic factor is not responsible for psoriasis and even other chronic diseases also. Epigenetic modification along with environmental factors and lifestyle, these two things are very dangerous. Environmental and lifestyle, they can modify along with their line the genetic expression. All these together influence the immune system activation. That means having a genetic predisposition modified by lifestyle and other environmental factors can trigger the epigenetic modification, and these things can start the immune system activation. The ultimate result is proliferation in epidermis and vasodilatation in the dermis area of the skin, and psoriasis develop. Here are the few genes, psoriasis susceptible genes, and their pathways. I'm not detailing here. Few identified alleles are there, namely HLA, HLA-CW6, HLA-DQ, CCHCR1, CUIP14, etc. And few common loci are there, PSORS1, PSORS-AS1, like that. But in a word, if there is a genetic predisposition, if both parents are affected, then the 40% chance having a psoriasis of their son or daughter. If one parent is suffering or suffered, only 14% chance of having psoriasis of the patient. And if sibling is affected, only 6% chance is there. Now, role of triggering factor. This diagram, you should understand it. Psoriasis is happening due to genetic background. In this model, we can see it. It can onset, genetic background can onset psoriasis, but trigger factors are there. And this is two types: extrinsic risk factor and someone intrinsic risk factor. In extrinsic factors, there are mechanical stress, air pollution, drug, vaccination, infection, smoking, alcohol. These are the common extrinsic risk factor which can trigger genetic background or exaggeration of persisting psoriasis. That means they can trigger and they can aggravate the existing psoriasis of a patient. And in mechanical stress, we know Koebner phenomena and ultraviolet radiation also another factor. In air pollution, it is interesting to see cadmium. Cadmium is a polluting agent, and researcher found cadmium in a high degree in a blood level of a psoriasis affecting people. Another pollutant, polycystic aromatic hydrocarbons. Others are volatile organic compounds. These also pollutant or pollution components, pollutants can trigger psoriasis. In drugs, anti-malarial drugs, lithium, beta blocker, these are NSAIDs. These are the common drugs which can trigger or exaggerate psoriasis in any time, along with the genetic predisposition. And another most important, vaccination. Studies show association between influenza vaccine and exaggeration of psoriasis is very close. And in intrinsic risk factor, there are metabolic syndrome, obesity, diabetes, dyslipidemia, hypertension, mental stress. That means lifestyle disorders. In a word, these are called lifestyle disorders, and these can also lifestyle can also affect genetic background to produce psoriasis. Most interesting thing is a stress. It can produce everything. Studies show 31 to 88% patients report stress as a trigger factor for their psoriasis. 31 to 88%. That means stress has a great role to produce psoriasis as a trigger factor. It works in the hypothalamo-pituitary axis and ACTH, sympathetic nervous system, neuropeptidase, which can ultimately trigger or produce pro-inflammatory cytokines, which can initiate the inflammatory cascade for production of psoriasis. New things appear in research. It is gut-brain-skin axis. Gut-brain-skin axis. Here an association of psoriasis, depression, and gut microbia are established. Psoriasis and depression alter the gut barrier function. Lipopolysaccharides reaches the bloodstream and stimulate pro-inflammatory cytokines. This is the mechanism by depression and psoriasis alter the gut barrier function. Ultimately, lipopolysaccharide reaches the bloodstream and they can stimulate the inflammatory cascade by producing different pro-inflammatory factors, cytokines. Now, what are the relevance to study these things in this way? Because our master Hahnemann clearly stated that a secondary manifestation of miasm, or suppose a patient suffering from psoriasis, that individual patient, his sufferings, his symptomatology are started long year back or long time back. Suppose when a skin disease is suppressed, primary manifestation when suppressed, and he or she remain in a latent stage. 200 years back, Hahnemann clearly stated that two things are required to initiate these reactions from latent to secondary manifestation. One is trigger factor, another is accessory circumstances or accompanying modalities. Most important trigger factor, grief, vexation, etc. That means stress, related to stress or mental trauma. Another, exhalation from swamp, acute disease, shock, burn, that means injury, pollution, etc. We have already see it in few previous slide back that how these trigger factor can trigger genetic predisposed people. And another is accessory circumstances, habit, diet, mode of living. That means if suppose grief is a trigger factor. Suppose one patient have a mental trauma from some incidents, but his mode of living, his age, his custom, culture, diet, all in a regulated mode, he or she will not be affected or not manifest secondary manifestation easily. But there are trigger factor. Suppose grief, and patient had bad habits, not taking proper diet irregularities, his mode of living is not good, his age is advanced, culture is not proper. These things can modify or can enhance the secondary manifestation. Here we can consider the psoriasis patient suffering, suppose an individual suffering from psoriasis, it is a secondary manifestation of any miasm or combination of that. Dr. J. Allen give few skin symptoms to differentiate the miasms. I am not telling all the features or differentiating point between miasms. Here I want to specify only skin symptom. Though previously I am telling that I have told that uh, here we should consider the person as a whole. Though the patient is suffering from a skin disease, a local malady, but we should consider the patient as a whole. But here I only mention few symptoms, not all symptoms, as because for this time there is no itching in the syphilitic and very little soreness. That means psoriatic patient have itching, but in syphilitic patient there is no or very little itching or little soreness. Skin lesion of psoriasis, psora, skin loses all moisture and become exceedingly dry. That means skin of a psoriatic patient will become dry and free from oil. In opposite side, the skin is very oily and greasy of the psychotic patient. Regarding scales and crust, which is mostly related to psoriasis, the syphilitic patient have thick and heavy crust, while the psora are thin, light, fine, and small crust. And in distribution also, psoriatic distribution is quite universal, while syphilitic and psychotic distribution is patchy or circumscribed. Concept of psoriasis in homeopathy as a complex disease or incurable disease. We all know that. All homeopathic clinician knows that psoriasis is difficult to treat. because it's recurrence. Few months, few years after, it can easily recur. Why this type of incurability happen, or why it is a complex disease? Dr. Allen also stated that psoriasis has a gouty element so characteristic of psychosis. I previously told in time of telling about the pathophysiology that proliferation, overgrowth is related to the original pathology of psoriasis. Psoriasis is dependent upon a blood state belong to gout and rheumatism. That means psoriasis, gout, rheumatism in the same line. Psoriasis, however, depend largely on soda. Dr. Allen stressed on soda. The free indulgence in meat tend to aggravate this eruption. Here he pointed out a dietetic factor, meat. Previous slide, few slide back, we have seen that gut-brain skin axis. And vaccination is generally the exciting cause. Meat, alcoholic beverages, wine, nitrogenous food of all kinds aggravate both the gouty condition and the disease based upon it. And when we look into such skin diseases, we will find all the chronic miasm present. It is the point. All the chronic miasm are present. These miasm are intermingled with each other, and where we find them all present, we usually find an incurable skin disease, especially if hereditary. Dr. Roberts clearly stated psoriasis has been called the marriage of all miasm or stigmata, but its characteristics are predominantly psoric and psychotic. Now the question of external application. Hahnemann clearly denied, told it that external application should not be done. Why? There are 4 reasons he pointed out. In aphorism 197, he told the chief symptom will usually be annihilated sooner than the internal disease. That means the man is totally diseased. Not only his skin is diseased. The chief symptom annihilated sooner. Another point, at least it will be difficult to determine that the general disease is destroyed or not. Skin symptom is not now. We cannot understand that internal disease is there or not. Aphorism 201. Another point, he pointed out that transfer the internal disease to a vicarious local affection is the point about suppression. And as it were, draw it thither from skin to internal organ. 202. Nature make up for its loss by rousing the internal malady. That means if we suppress our skin diseases, our internal organ will be damaged. Dr. Ellis Barker, he nicely told, vast majority of skin diseases, practically all skin diseases, are not local but systemic. Hence, they ought to be treated constitutionally. They ought to be treated constitutionally, not focusing on the local symptom. No skin disease can be cured by giving it a Latin name and prescribing sulfur ointment, mercury ointment, etc. Here, I have given 2 to 3 cases from our masters. First case, here prescription medicine was prescribed, particularly emphasis on a past history. A 42 years woman, psoriasis, diameter 2 centimeter approx, over trunk and limb, appear after treatment of tonsillitis with sulfapyridine. That means treatment with a drug. After that, psoriasis appeared, and primarily arsenic album was given, no improvement. Here I am telling one thing, that arsenic album previously was many times used for psoriasis even before homeopathy has originated. But after arsenic album, no improvement happened. Then he gave sulfapyridine 30. The case is cleared up, not returned within 6 years. Another, Dr. Richard Hughes, a general psoriasis of 4 years standing, 10 years girl. First week was traced to vaccination. Another cause, vaccination. aggravation by overdosing of arsenic. Here also arsenic was used. He gave Thuja in second and third dilution, caused an 2 and 3, followed by 3, and caused an almost complete recovery. Lower potency, centesimal. Another case from DM Fobista. 9-year girl suffering from psoriasis, small rounded areas, preferably gutted psoriasis, less than 1 centimeter diameter, appear after a fright. Previously, I have told that stress is a key factor. 8 to 31 to 80% cases appeared after mental stress. Appear after a fright, but over telephonic conversation, he gave opium CM, but no apparent benefit. After seeing the case, that means after case taking, he gave Oramme 200. This medicine also covered the rubric, the effect of fright, first aggravate the condition, then cleared up, return after a few months, and then he prescribed Oramme 10M, not return within 2 years. That means here, previously, medicine only focusing on the past history, a history of stress given, but it did not work. After proper case taking, that means totality of symptom, constitutional symptom, give the clue to another medicine which is more homeopathic to the case which was Oramet. Now, what should be our plan to treat psoriasis patient? First, take the case in detail. Try to collect the most significant point of the whole history of chronic disease. What anyone already told. Significant past history. These points are remaining in a case-taking format, but many a times we take these points in a very easy manner, not in detail. Here we should not miss it. Significant past history, family history, personal details, personal history should not be overlooked, because already I have told that here we can find few clues for our prescribing and individualize the patient as a whole, not his only considering his skin disease, skin symptom, considering his soma and psyche both. Prescribe according to similimum, not focusing on no undue emphasis on local symptom. That means character of scale, character of discharge, pass is there or not. These symptoms are, if very much characteristic, we should consider it. But only focusing on this symptom will not be benefited in a long run to the patient. Prescribe a single medicine at a time with minimum dose. Stop unnecessary repetition. Plan for proper diet and regime. Without proper diet, gut, brain, skin axis. Without proper diet, it should not be corrected. Keep patience in an eminent degree during follow-up also. Patience is required in the end of physician and also in the end of patient. Few rubrics from Kent Repertory, skin eruption psoriasis, few drugs are there. I have mentioned here only few drugs and few rubrics. Arsiod, lycopodium, phytolacca sepia, Kent Repertory, skin eruption psoriasis, syphilitic, Arsiod, mercury, phytolacca, complete repertory. There are many medicines, arsenic, arsiod, hydrocortyl, lobelia, lyco, like that. And complete repertory, few other rubrics. I have mentioned here only few. Skin eruption psoriasis gyrator. One medicine is hydrocortyl. Skin eruption psoriasis vaccination after. Vaccination after Sorinam. Grief after Staphysagrria. And one alternating symptom, respiration asthmatic alternating with psoriasis. That means asthma alternate with psoriasis, sulfur is the medicine mentioned here, and skin eruption psoriasis, fingernails, that is the site related rubric, sepia. There are many rubric related to site, knee, elbow, right, left, upper, lower extremities, like that. Vatak repertory, uh, here also mentioned arsiod, clematis, dulcamara, graphitis, sepia, sulfur, palm, petroleum, phosphorus, selenium. So few rubrics are there like psoriasis, itching without. Few medicines from materia medica portion, arsenic iode, chronic skin affection. Here I not try to mention many drugs or many rubrics, as because it is depending prescription will be depending on the totality of symptom, and after individualization you should select a medicine. It, it may be any medicine, it can be given to the patient according to he, him or her totality of the symptom. So there are no need of mention many therapeutics or many rubrics here. Arsiod, chronic skin affection, psoriasis, the inflamed and scaly eruption almost cover the child. Arsenic album, brand-like dry scaly eruption with itching and burning is the characteristic. Also, I have mentioned here only skin symptom. Arsenic album will not prescribe only on skin symptom. There should be incorporated a mental general, physical general, like that. Hydrocotyle, another drug commonly used, dry eruption, great thickening of epidermoid layer, and exfoliation of scalp. Psoriasis gyrata on trunk, extremity, palm sole, etc. Caliars, another medicine, scaly itching, causing him to scratch till an ichorous fluid discharges. Phytolacca, old cases where sulfur did not grow. The miasmatic indication. Sepia, red spot and papules, isolated and in large oval patches covered with itching. Psoriasis, this symptom taken from herring. Thyroidinum, psoriasis associated with adiposity. Adiposity is one of the risk factor previously I mentioned. Not developing stage, skin dry, improvised, itching without eruption towards night. X-ray, dry itching eczema, erythema around root of nail, nail is here affected, skin dry, wrinkled, nail thick, and psoriasis. And many medicines are there: sulfur, mercury, thuja, tuberculinum, calcarea, natramure, graphitis, etc. Now I am presenting uh, three cases here. In this case, first case is a Plantopalmer variety. Patient is suffering for many years. We have given him CPA in zero potency, but the dose was given only two at a time. That means 0, 1, 2 doses, 0, 2, 2 doses, like that. Here the picture before treatment, during, and after 6 month follow up. Patient is still under our treatment, but recent photos is not my hand. Here only I have given only 6 month follow up. Patient is better now. Thuja was prescribed to him, CPR 0 potency, and followed by Thuja 200 one dose. And his lesions, Plantopalmer variety, a plantar area and sole, it is cleared after 6 months. It is totally cleared. There is a corn, is two corns are there. They are remaining almost same in position, same in character. Not so much changes in corn, but psoriatic lesion almost gone. We have to wait for the recurrence of the symptoms, or we have to wait a long time, follow up this patient if we want to tell that patient is cured. Another patient before treatment, this picture, first picture is before treatment, and we gave him after case taking natramine 0 by 2. Here also we gave few doses, only two doses, and after two doses at the day fourth there was aggravation. You can see the middle picture, and after 20 days it is almost healed up and much better from previous. It is also given now under our treatment. Another is pustular variety. It's a very severe form, and leg was swelled up. There was a history. Patient was 40 years age, male patient. After playing football in dirty water and mud in the field, and after an injury, this psoriatic lesion aggravated. He was suffering for last 2 years, and it severely aggravated, become a pustular form, pustular psoriasis. He consulted allopathic physician in the hospital. They gave him antibiotics, but patient did not take it. He want to take homeopathic medicines and came to us. In this case, we gave him first the echinacea, and after 2 weeks, we gave natramine 01, only one dose, and a fourth photo showing the improvement after 2 months. This pustular form is a very severe form, and it is managed with only homeopathic medicine and only few doses. And specifically, here I mention 3 cases which are treated with zero potency and only 1 or 2 dose, not 14, 16 or continuous doses. Now, another area, research. Without telling something about research, it will not good to present a seminar or present a CME. It's a PASI, PASI, Psoriasis Area and Severity Index. This scale can help us to measure psoriatic lesion, their improvements in a follow-up also. There's 3 subsections, and here are the rules how to calculate the PASI score and what are the interpretation of PASI score. Here I have given few examples from recent researches, publications, treatment strategies against psoriasis, principles and perspective of practices. Another is complementary medicine and psoriasis, linking the patient's outlook and evidence-based medicine. Individualized homeopathic medicine in the treatment of psoriasis vulgaris, double-blind randomized placebo-controlled trial. It is from NIH. Here I have given the result section where statistically significant improvement in the individualized homeopathic medicine group, and they are given the scales were PASI and DLQI. Two scales and activity subscale scores are given, and another is medicines are prescribed, frequently used medicine in this study were calcarea carb, mark salt, arsenic, petroleum. What are written in the result section, only abstract is available, not the full paper. Few other case reports here, psoriasis cases of some diagnoses but different phenotypes from George Vidulkas, management through individualized homeopathic therapy. Another is homeopathic treatment of patient with psoriasis, a prospective observational study with 2 years follow-up. It is prospective observational study, 2 year with 2 year follow-up. Exacerbation of pustular psoriasis in mercury poisoning. It is a research paper not from the homeopathic field. Here they have found that pustular psoriasis in a case where mercury poisoning was happened. It's a rare case, but mercury poisoning and pustular psoriasis somehow related. We can understand from this paper. So here I have given some examples of case reports, randomized controlled trials, observational studies, etc. But one thing I want to tell here, homeopathy is based on basically philosophy, and it is a philosophy based therapeutic system. And here It is also a personalized medicinal system, personalized therapeutic system, personalized medicine. In this case, I think better model should be mixed method research, where quantitative and qualitative data simultaneously analyzed. Because to treat a patient, not only the psoriasis, to treat a patient according to homeopathic principle, they need an expertise. Physician may be senior one, or he can he is following the examples from previous teachers. That means there are a need of qualitative data to prescribe medicines in the cases in homeopathy, as well as simultaneously their need of quantitative analysis also. Both qualitative and quantitative data can explain the homeopathy in a scientific manner. It is a personal opinion from my end. I think mixed method research will be a future research prospect in the field of homeopathy. Conclusion: considering all the factors, we should make a totality, and it is an important thing in these skin diseases like psoriasis. After proper selection, another effort should be given to select potency and dose. These two things also important. When we select zero potency, there is no need to give many doses in a routine. That means 16 doses in every case. It is not required. There may be required only one or two doses also, even in zero potency, and according to the susceptibility of the patient and other factors. That means individualization should be done in case of potency selection, in case of repetition dose also, and in case of diet also. Sometimes there may be use of second, third cup in case of zero potency to minimize aggravation. For the centesimal potency also, we should be more careful to choose potency and dose to avoid unnecessary aggravation. Here, individual expertise of the physician can play an important role. Another challenge is to stop the recurrence. Why it is become incurable or very difficult to treat disease. In the case of the psoriasis patient, it is really a challenging task. So, being a local malady, psoriasis should be treated in an individual manner with following strict homeopathic principles, which may bring the light in the pathway of curing the disease individually. Thank you. I want to thanks to NIH Alumni Association for giving me the chance to deliver my topic in the CME, and I am also thankful to Dr. Bidyut Mukherjee, and I also want to give thanks to Professor Dr. Subhasis Ganguly, HOD, Bardhaman of Medicine, DND Homeopathic Medical College and Hospital, and thank you all for your patience here.
Am I audible?
Yes, sir.
Thank you, Dr. Pulakendu, for his nice presentation. Very good presentation. At first, your mode of speaking, that is a pace of speaking in a seminar, that is very, very important. Because you have explained everything in a particular pace so that everybody can understand what you intend to speak. And I think all the viewers of this channel, they have understood what today's speaker, Dr. Pulakendu, wants to explain, because psoriasis is a very vast area. He has explained everything. He has pointed out from definition of psoriasis, pathophysiology of psoriasis, that is different through inflammatory factors, and how that is basically the overgrowth occurring, and what is the what are the clinical features. In nutshell, he has explained in that way. As being a homeopathic doctor, they can memorize every symptoms. If those viewers they have attended or in future from the YouTube, I think I will request every viewer to hear repeatedly this seminar so that you can get a full understanding of what is psoriasis and what are the symptoms, how you can identify them, how you types of psoriasis, and explain the DD, how to differentiate from the psoriasis to atopic dermatitis to seborrhea, tinea, everything. Because I think he has selected this DD, those we are getting in our day-to-day practice. Very good, fantastic. And regarding etiology, he has explained, and from the types of the psoriasis, there is a gutta psoriasis from the repeated streptococcal infection. From this standpoint, when I think, in that case, after hearing this presentation, being a moderator, uh, I may think of the one case I failed in psoriasis because at that time that is a repeated tonsillitis was there. I forget to prescribe the streptococcal. I think that in that case, from his explanation, from his presentation, he has explained nicely from homeopathic point of view how we can prescribe a homeopathic medicine, from the miasmatic point of view how we can uh, explain the what are the character of the psoriatic lesion. From the psoriatic lesion, from the scabs, we can find it out what miasm is lurking behind. Basically, the psora will be there. Without psora, cytosis and syphilis cannot invade. From the sodic dominancy, from syphilitic dominancy, from zygotic dominancy, what will be the characteristics? From classification to everything he has nicely presented, very nicely presented. And also, he has told the cadmium in the very high level from the researcher it has shown. If we see the cadmium sulf is our medicine, from the research, why we have to uh, involve ourselves to go through go to read from different research papers. We have to read our repertory, we have to read our Mathematica, organon, practice of medicine, everything. Also, being a homeopathic doctor, we have to habituate to read, go through the different research papers because the research also ignite you to think of different medicine. Like if the cadmium is there, our medicine is the cadmium salt. But I do not want to say that from that level I have to prescribe the cadmium. If every medicine we are failing, if the cadmium is in blood is very high, in the cadmium salt, in the skin, there is a psoriasis is not there, but is not written over there. But itching, scaly, cracks, these are mentioned. So from this presentation, another medicine we can think of the cadmium sulfates. We have many patients we are getting in our OPD that they are taking the habit of taking the NSID. So NSI has told the NSID as an influenza vaccine. Nowadays, elderly persons are taking the influenza vaccine. that may, and the late onset of the psoriasis that may be occurred from the influenza vaccine. So what medicine we can think of for the vaccination from the organal point of view, from the mathematical point of view, we have to think. There's a and he has very clearly explained the role of the fundamental causes in psoriasis from the organal point of view and how to also he has very clearly mentioned our master Dr. Samuel Hahnemann how he has explained in our organal medicine in different aphorisms. He has shown few cases of scholars of DM Fogister that he has explained, which he has explained in his presentation. That the stress is a factor, fright is a factor, from the epigenetic factors which excite the genetic factor. Fear and stress also playing a very good role or excite the lesions of the psoriasis. That is why he has designed his presentation in that way. That is why he have shown the DM Fogister case where DM Fogister mostly he prescribed higher and higher potency, start from the moderate to the straight to the higher potency. Why opium failed and why aromatic was active, he has explained. And also, in one slide, he has explained there is a plan of treatment. That is very, very important. That plan he also showed that lifestyle disorder is the diet is the important factor. So everything we are taking into the consideration during our treatment of the patient. We can prescribe a medicine to our patient, but we from the personal history, different distress factor. These will get mostly in the personal history. That is, I may request to the all the viewers say that whenever we are getting any obstruction or we are not getting the clear cut pathway, that the personal history help us. We may get the different stress factors because personal history, suppose the patient daughter remain unmarried, his son is not getting job, patient if have came to us for the different skin lesions. If we ignore this stress factor, so we will miss some symptoms. We may prescribe the wrong medicine. So in that way, he has very clearly our speaker very clearly explained what are the area we have to think of before prescription. And different, he has clearly mentioned different medicines, very medicines mostly commonly appearing in our day-to-day practice, including hydrocodone, asiatic everything, and thyroidinum and X-ray. He has shown his three remarkable improvement cases, and he has explained how he selected the medicine, and very critically he mentioned what is the potency he prescribed and why the LN potency, and very thought-provoking, and few senior teachers already were not present in the world, very senior teachers, we know that they had the practice to prescribe one of the two doses of the LN potency, though it is not mentioned in the C section of organ. But mostly they are prescribing in the skin conditions or skin disease condition because moderate potency, even the low potency, high potency may excite the condition in that way. That is very uh, difficult to manage. That is why I think Dr. Pulakendu had already gained some experience and very good experience of treating different kind of patient. He can assess the susceptibility of the patient. That is why he prescribes starts with the LM, even the shorter the potency dose. one or the two doses and he got the remarkable improvement. And that is very thought-provoking. We may think of, we may prescribe in that way, but routinely we may not prescribe, which is mentioned in the sixth edition of our own medicine. So that is the individuality. Every patient is individual. If this medicine, they are giving their symptoms from the susceptible point of view that is different. And he has shown that the PASI, that is the psoriasis area and the severity index, very good because we, as I also am in the family of the DNDN, now because I am working there and there the PGTs are there are different research programs going on, and in every week seminar we are making a habit that whenever seminar is going on with the particular PGT, they are suppose on the particular disease, they are giving some valid scale in printed form. It is my request to all the viewers, which Dr. Pulakendu have shown, please go through the PASI scale. If you want to treat the PASI, psoriasis, maintain the PASI scale in your chamber so that in the uh, your consecutive prescription, you can understand from the observation and the black and white paper in both ways, it will stand that your medicine is working or whether the patient is not getting help. So, and also you have shown different research papers. So, and at last, being a researcher, being a very good clinician, also he has shown there is a what is the utility of the mixed method, because that in future we have to go through the mixed method approach where quantitative and qualitative data altogether we have to consider. So thank you, Pulakendu, for a very good, nice presentation, thought-provoking presentation. And I think everybody will be benefited after hearing repeatedly of psoriasis seminar of today. Being a moderator, I want to add, if you allow me, Pulakendu have given a very nice presentation, but I want to add one or the two. Uh, you have
Sure, sure,
shown
sir.
all the approaches. You have shown all the approaches. Yes. Also, you have shown. Also, you have said that is in repertory under the different locations we are getting this psoriasis. But I think within a 1 hour time, it is not possible to everything to show. But I want to concentrate on that crowd because he has
Sir,
lived that.
I am eagerly waiting from hear from you, sir. I'm
Okay.
eagerly
No,
waiting here from you, sir.
no. You have covered every aspect. You have covered every
No,
aspect.
no, sir.
But
Please, sir.
as it is a very vast, uh, any seminar, if it is beyond the 1 hour, I think viewer cannot retain every
Yes.
data what you are saying. And your presentation is very good. I'm not criticizing, but I want to add, I have to garnish to your seminar.
Yes.
Okay,
Sure, sir.
just nothing else, nothing else. If you simple, uh, simple, if we going through the Kent repertory, extremities chapter, and in the left hand side you write down the symptomatology, straight you will get how Dr. Kane has mentioned, had designed these symptoms in a logico-utilitarian type. I think, Dr. Pulakendu, we are not getting the lesion in the buttock region. We are not getting the lesion in the thigh region in the primary. When it is a very advanced, then lesion is extending that level. That is why if you open the extremities lower limb, you will not get in the next region, in the thigh region, you will not get this psoriasis. But if we go to the knee, we will get this psoriasis. Even if you go to the leg, we are getting this psoriasis. In ankle region, we will not getting this psoriasis. In feet region, we will not getting the psoriasis. That means, doctor, improving symptoms. or in accidental proving or the clinical symptoms, usually not affecting those areas. That is why in our Kent repertory, most authentic repertory till date, we are not getting the lesion and on that region. Similarly, we are not getting this in the shoulder region. But very funny thing, we are getting this psoriasis in the first finger. Actually, first finger is indicating the index in repertory. Thumb is written first finger, second, third, fourth. That is the index, middle, ring, and the little. And if we open the Kent repertory extremities chapter, then going to the lower limb, upper limb, ultimately the finger, first finger, psoriasis we are getting. Two medicine, that is the Anagalis and Euthia. I'm not telling to the viewers from that you can prescribe the Anagalis and Euthia. At least our repertory is excited to add another two medicine, that Anagalis. I have to go through the core books whether Anagalis have the symptoms. And Dr. Kent have shown the Anagalis and Euthia. So what is the utility of the repertory? Repertory is adding the more number of the medicine we can think of. Similarly, if you open the psoriasis in the palm, there are the many medicine, but phosphorus is the first grade medicine. Phosphorus is the first grade. And if we go through the elbow region, that is the most common, is extensor surface. We are getting the iris first. Similarly, open the knee, extremities knee, psoriasis, iris verse, both second grade. And if you open the body, iris verse skin, it is clearly written psoriasis is there in the italics. And this, in the first line in the skin, if the skin symptom associated with the hyperacidity, we can think of the iris verse. So in that way, iris verse we may add, pictum meram we may add, anagalis we may add. From the location, that is another indication we may think of, as you shown, the knee region, but you have prescribed the nectar I think. So I'm not telling to the viewers by seeing from just opening the repertory, because repertory is not the final court of appeal. Final court of appeal is our BTMI. So we again I'm congratulate our speaker Dr. Pulakendu for his nice presentation. All the viewers who are attending to this seminar, I think they're very much benefited.
So
My
few questions are there, sir. Few questions are there.
Three questions. How many questions? Three questions. But I'm not.
Sir, I am telling. Dr. Beni Madhav Sadhu Khan.
Okay. I've received. One question, Dr. Beni Madhav Sadhu Khan.
Psoriasis without hypertension.
Yes, psoriasis without hypertension is not available. Hypertension is a factor of skin disease. Autoimmunity is also associated with hypertension.
Yes, sir. I have mentioned it in a word: lifestyle disease. Lifestyle disease. It covers diabetes, hypertension, dyslipidemia, cancer, even psychiatric illness, even also thyroid problems like that, hypothyroidism like that. Okay.
Yes.
And obesity. There, in this, I am again showing. This slide is very important. So previously I have also told, in right side, intrinsic risk factor, here is metabolic syndrome, obesity, diabetes, dyslipidemia, hypertension, mental stress. These factors are mentioned there. And hypertension also a key factor which can trigger the psoriasis.
Okay, I think it is clear to everybody. Next question is the Shandip Kamse.
Yes. In case of aggravation of itching of psoriasis, what is approach or methods given? And what is zero potency? Zero potency is LM potency.
LM potency.
LM potency. In case of aggravation, I think we need I've already mentioned that we need patience in eminent degree in case of follow-up also. Symptom may be aggravated, but somehow it may be disease aggravation, it may be homeopathic aggravation, and these kind of differentiate between these aggravation is very difficult. And in that point, we somehow we should manage the patient, counsel him or her, and give placebo, not change frequently. If your medicine selection is good, or if you have confidence, I think if you have confidence over your medicine, then not change your medicine frequently, especially in case of psoriasis, because ups and downs, remission and reappearance, the basic characteristic thing of psoriasis. Modern medicine also mentioned it. Only somehow aggravation of itching is not a point to change or potency or drug whatsoever. Another question is, when patient approaches after allopathic treatment for years with lot of suppression with multiple ointments, how this case to be managed? Uh, in case of skin disease, we should not allow any kind of allopathic medication or ointment from first day of our treatment. First stop it, then only after few days or few months, original symptom, chance of returning original symptom will be there. But if you allow these ointments or steroids to treat these kind of patients, our selection will not be good. Okay, thank you. These are the questions, sir.
Yes. I want to add one thing with the last questions. Your answer is nice.
Okay, sir.
If you open the generalities chapter of 10th repertory, uh, I think who is the last viewer, last who plays the last question?
Dr. Sandeep Kanse.
Okay, okay. A generalist chapter, that is the irritability. When too much medicine has produced an oversensitive state and remedies fail to act, phosphoric acid and teucrium. Here, teucrium is a phosphate, and teucrium is showing the different location area. If your location, considering the teucrium along with these symptoms, we may start with the case with the teucrium, madam also, and wait for some times, some months, yes. Then you can, I think, will get the similarity, some symptoms for prescription.
Okay, sir.
Thank you.
Thank you.
Thank you to all the viewers, my respected Kalyani sir, my senior Dada, Bidyut, Dr. Bidyut Mukherjee, and backstage, Mr. I think Dr. Orko. Everybody always support us to interact with the viewers in that platform. I think the NH Alumni Association is maintaining this, and I think within short span of period we'll cross this century.
Right, Rajat. Thank you so much. I am really proud of our alumnus, Dr. Pulakendu, Professor Raju, and why not? Because we have our mentors like Kalyani sir, Sarkar sir, LM Khan sir, SKB, S. Adhikari sir, so many names to be mentioned. So
Yes, yes,
we are product of our seniors. And
yes,
now it's your turn, Rajat Pulakendu, to bring future stalwarts from various colleges across the country. That we are from NIH. Kalyani sir on stage. And before that, I'll request all the viewers
yes, sure.
Please hold on. We are having some technical snacks. Just hold on for a moment. Kalyani sir, you just give your some inputs until father arrives. You just continue, sir. Kalyani sir, over to you, sir. Sir, you take over, sir. Viewers, there are some internet snacks. Please hold on until then, as we go on with it. And we are trying to have something. Please hold on. Until then, viewers who are watching live and who will be watching on the recorded version, let me just again tell you with this, you can just get your auto e-generated certificate from the link in the description. Please go and click on the link and take your auto e-generation certificate until our network gets restored, our host network gets restored. Uh, Both of our hosts, Kalyani sir and Dr. Bidyut Mukherjee, are facing technical issues and also network issues. Please hold until then. Until then, you can do is join the WhatsApp channel, Telegram channel, and also like our Facebook page, and also share this live stream with your fellow homeopaths you know, also the fellow alumnus, also to your teachers, non-teaching staffs, and everyone you know. Kalyani sir, hello Kalyani sir, can you hear me, sir? Kalyani sir is not audible. Um, Hello, Dr. Bidyut, are you audible? Can't hear you.
Hello.
Hello, please wait, sir. Just wait a moment, Pulakendu sir and Rajat sir. Please wait a moment. Kalyani sir, can you hear me, sir?
There is some disturbance.
Yes, sir. There is some disturbance with the network, sir. Uh, the program was going perfectly, but at the end there are some network glitches. Both of our hosts. Until then, uh, Rajat sir, am I audible to you?
Yes.
Rajat sir, for on live, just let me make one thing clear. I am not yet a doctor yet. I am currently a medical student.
Okay.
Uh,
Okay.
so
I think you have
I am a
passed.
final year
Okay.
student. No, I am a final year student, and I have my exams
Okay.
this coming 2024.
Okay. January 24.
Sir, just please wait because both of the hosts are facing network glitches. Just please wait until then.
Big problem. So we are waiting. No problem.
Kalyani sir, Kalyani sir, I
Ah,
think it's clear now. It's clear now. You can just stop.
now it's clear after a long time.
Yes, sir. Yes, sir. Over to you, sir. You just conclude the session, sir.
Anyway, with constraints on network system, Am I audible clearly?
Yes, yes.
Yes, sir.
So much of network disturbance
Sir, I
was
think you
there.
should conclude it.
Yes, we are about to conclude, but both of our hosts are facing this internet issues. What has happened, I don't know. Hello, Dr. Bidyut, can you hear me? Ava?
Good evening. We are
Over to
facing
you.
network challenges in our uh, same with Kalyani sir and myself. Sorry, viewers, for this technical snack. We are trying to promote VSNL, but anyway,
It is our bad luck
now
today.
we were requesting all the alumni across the globe to kindly share your experiences in the CME and also in our e-journal, Sapre Audi. The next issue is due to publish in December, but we request all the viewers, whoever are viewing it, please go through the e-journal, and our alumni across the globe, please come forward in any of the numbers or the email ID given in the description. Send your articles, be a speaker, and share your experiences. Don't hesitate that I am not a teacher, I am only a practitioner, because everybody can help each other to help themselves and promote and propagate proper homeopathy through the basic thoughts of our master Samuel Hahnemann sir. Now we are waiting for Kalyani sir. Also, if Kalyani sir can respond, Kalyani sir again got detached. And we like to thank Dr. Pulakendu and also Professor Rajat. Pulakendu, you will be getting a certificate of speaker, which will be sent to you through over your Telegram account or to your WhatsApp account. A digital certificate which you can take a print out. Uh, Waiting for Kalyani sir. Over to you, sir, to conclude. Dr. Kalyani sir. Orko?
I think
Uh, Over to you, sir.
I guess since there are so many technical snacks, can we just end? Because Kalyani
Oh,
sir,
anyway,
from
Kalyani sir
Kalyani
got
sir,
this. Kalyani sir, with the permission from, with the permission of our moderator tonight, let's conclude the program, and we'll be meeting again. With your permission, moderators, Professor Rajat,
yes,
we are
yes.
concluding tonight's
Sure,
program and
sure.
meeting
Yes.
again
I think
on
Kulani sir,
29th
Kulani sir
of
will join. I think
October.
Kulani will join.
Yeah, right, right, right. We want to hear from Kalyani sir. Yeah, so please.
Network issue. Network issue. Sir. Sir, you may,
Kalyani sir, over to you, sir.
sir, audible? Sir. I think Bidyut, you should conclude because
Yes.
It's best to conclude, sir. I guess it will be Dr. Bidyut, sir, Baba, please continue. Since there was some technical issue, so I am just closing. Rajat sir, can we conclude now?
Yes, yes.
yes, yes, yes,
Sir,
yes,
please.
yes.
Okay,
It
thank
is our
you,
bad luck
sir.
because yeah,
Yes, sir, it's our bad
Network
luck
issue.
totally.
Okay,
this
sir.
program is concluded. Yes, with permission
Thank you,
of
sir.
yeah, we are concluding here.
Okay.
Okay,
Thank you.
Okay,
good night.
so with some talks with this before concluding, I just want to tell something to the viewers and also with you all. I want to share with some things. So, as said earlier, to all the viewers and all the panel members in the backstage, you can now get NIH related updates about anything, about everything in our Instagram page, WhatsApp channel, Telegram channel, and also in our Facebook page. So do make sure to like our Facebook, follow our Instagram channel, follow the Telegram channel and WhatsApp channel to get updated for this CMEs and also all the updates about NIH and NIH alumni. So with this, let's just conclude tonight. And if you want to get an auto e-generated certificate, please make sure this is for the viewers only who are watching live. The auto e-generated certificate will be available till 12 a.m. After which the participation certificate will be closed. So it's up to you guys to click on the link given in the description below to get your auto e-generated certificate. So with this, with my other two panel members, Rajat sir and Pulakendu sir, we are taking a good night. We are saying good night to
Thank you.
you
Good
all.
night.
Okay,
Good night. Thank you.
Thank you.
okay, okay. We are leaving. We are leaving.